Good afternoon. My name is Esther Smith-Howell, and I am a BSN PhD student at IU, or Indiana University, Purdue University at Indianapolis. I'd like to pay some tribute to my funding sources, which Dr. Haberman spoke to. The T32, F31. Also, I was a behavioral cooperative oncology group fellow which was funded by the Mary Margaret Walter program, and also I'm a Johnson & Johnson AACN scholar. So I'm going to be talking about recruitment strategies for bereaved African American family members of patients that died as a result of advanced cancer. I'm going to give you a little bit of background, research priority of end of life, research of recruitment strategies, my pilot study, the recruitment procedures that I used, the unique recruitment strategies that I used, the lessons that I learned, and then implications for this vulnerable population. So if you're not familiar with African Americans at end of life, or African Americans in cancer, African Americans are affected by high morbidity and mortality rates as a result of cancer. Many African Americans could benefit from comfort-focused care such as hospice or palliative care. Hospice is the best form of treatment for dying patients, but unfortunately many African Americans choose life-prolonging treatments with little chance of cure. Now, the decision to continue life-prolonging treatment, we don't really understand the decision process well. It's complex, and there are many factors that go into that decision, to include patient and family characteristics, patient, family, and provider interactions. So, for example, a patient-family characteristic might be religion, their cultural values, socioeconomic status, like mainly demographic factors. And then the patient-family provider interactions include the relationship that the patient and family has with the provider and the communication that they have. The communication we have found to be critical to decision-making at end of life for African Americans. So effective communication among this population includes patient involvement in decision-making, so shared decision-making, knowledge and understanding that patients and families have, and high-quality medical decisions. So with communication comes high-quality decisions. The informed patient should have accurate and complete information about treatment options at end of life. Unfortunately, African Americans desire to be involved in the decision-making process, but their discussions are usually inadequate. They often report poor communication with providers. They often feel they have perceptions of discrimination or mistrust, as I'll talk about on the next slide. And they just do not have the information that they need. They don't have adequate understanding of their disease diagnosis, prognosis, or the treatment options that are available for them at the end of life. And so end of life is a research priority. Enhanced end of life discussions to better understand the decision-making process is important for patient-centered care. And so to improve African American decision-making at end of life, we really must understand the perceptions of the factors that are related to the decision to stop life-prolonging treatment or continue life-prolonging treatment. We also need to understand the factors that underlie the differences in prolonging or stopping that life-prolonging treatment. And so NIH generally, and specifically NINR, really has taken on the task of understanding end of life and doing that research. And it's particularly important among minorities, including African Americans. So African Americans continue to be a hard-to-reach population, specifically for mistrust, especially in this area. African Americans have had poor access to medical care. They have experienced discrimination blatantly, and they have also perceived discrimination. They have experienced injustice, past medical segregation. Of course, everybody knows about the Tuskegee study. And so ramifications from these past societal events have really rippled through medical care and medical research as well. And so investigators of bereaved family members and investigators of patients at end of life really encounter unique challenges in identifying, recruiting, and retaining these patients, because this is such a sensitive time in life. Patients often who are actively dying are too ill to participate. Their family members are busy. It's a very emotional time period, and so to have additional stressors put on you from a researcher is it's difficult. So I conducted a pilot study, and the aims of this study were to describe demographic characteristics and end-of-life decision-making outcomes, including decisional conflict and decision regret of African-American family members of deceased patients with advanced cancer. I also wanted to describe the African-American family members' experience of the end-of-life decision-making and communication with healthcare providers. And also, I wanted to look at the perceptions of the decision to either continue life-prolonging treatment or stop life-prolonging treatment. This was a mixed method study. The quantitative portion was cross-sectional, and the qualitative portion was qualitative descriptive. I recruited 10, I used convenience sampling and criterion sampling. Convenience for the quantitative, criterion for the qualitative. I recruited 10 family members of patients who had died of advanced cancer. The family member had to have died within 2 to 4 months at the time of recruitment. The quantitative portion of the study was a one-time telephone interview of 10 bereaved family members, and then the qualitative was a semi-structured interview of a subset of 5 participants. I recruited from a safety net hospital in the Indianapolis area from the palliative care program in that hospital. The decedents had to be an adult, 21 years or older, identified as an African American in the medical chart. They had to have died as a result of cancer or cancer-related condition, and received either comfort-focused care such as hospice or palliative care or life-prolonging treatments. The bereaved family member must have been an adult, self-described as African American, have been a family member by blood or close affiliation, to include fictive kin, which we know African Americans often have people that are close to them that may not be blood related, that they consider to be family. The family member had to have died within 2 to 4 months, and the person that I recruited, I wanted them to be somewhat or very involved in the patient's care, and of course able to speak English and read. So recruitment procedures. Participants were recruited from the safety net hospital. We followed HIPAA and IRB protocol. I collaborated with the palliative care program's database manager in order to figure out which patients met my eligibility criteria, and then look further to identify their family member who was listed as next of kin. I mailed introductory letters from the palliative care program medical director and also a study information sheet. I called them to describe the study. I answered any questions that they might have had. So this was a opt-out type of study. I included a phone number that they could call on the study information sheet if they did not want to be contacted. Otherwise, I contacted everyone that I sent a letter to. Once I talked to them, I invited participation, and if they verbally consented, I made sure that they were eligible for the study. I went ahead and collected data, and I asked them, was it okay for me to contact them again for the second portion of the study in the event that they met the criteria for the second part. So the second portion of the study, I recruited based on decisional conflict tertile scores, and I used decisional conflict because, well, I'll give you the definition of decisional conflict. This is when an individual experiences uncertainty about a course of action when the choice of options involve risk, loss, and challenges. And so we all know that end-of-life decision-making involves great uncertainty. Patients and families often do not know, if they haven't been given adequate information, they may not know what options are available. Even if they do have all the information, end-of-life is innately a difficult time in life to make decisions. And so I used Ottawa Decision Support Framework Decisional Conflict Scale, and this scale measured uncertainty in choosing treatment options, modifiable factors influencing decision making. I chose this because decisional conflict scores often vary by individual, so this will give me a really good idea of those individuals who had high conflict, moderate conflict, or low conflict. And people who have high conflict usually have delayed decision making. They may make very quick decisions, and this could be very detrimental at end of life, because if you are making quick decisions with inadequate information, it could result in poor outcomes for the patient and family, as research has shown. So for the qualitative portion, I recontacted people based on decisional conflict scores, or decisional tertile scores. So low conflict was 0 to 33 points, moderate was 34 to 67 points, and then high conflict was 68 to 100 points. Like the first portion of the study, I called them to describe the study. I answered any questions that they might have had, and I invited them to participate in the second study. I obtained verbal consent and then went ahead with data collection. So unique strategies, networking was key for me. I am a trainee with the Research in Palliative and End-of-Life Communication Training Center, or RESPECT Center, at Indiana University, Purdue University, Indianapolis. And the RESPECT Center is a collaborative, interdisciplinary community of researchers and clinicians that come together with the aim of advancing science of communication in palliative care and end-of-life across the lifespan. So from pediatrics to geriatrics. And so the medical director of the Safety Net Hospital is actually a member of the RESPECT Center, and so I was able to communicate with him and ask if I could use his site as a recruitment site. And he was very excited and enthusiastic about me conducting my study at his palliative care program. He then put me in contact with the database manager whom I work with in order to identify the patients and then the decedents. And then I was able to use the hospital's letterhead. The palliative care director signed each information sheet personally, and so I worked closely with this team in order to make the experience as personal as possible for these patients whom I had never met, but they knew the team, they didn't know me. So the information that I gave to the patients' families, the language had to be very sensitive. The introductory letter and also the study information sheet, I wanted to use language that really connected the family member to the deceased loved one. And so I said, the study is conducted by your loved one's physician's practice. And so they knew the medical director, and so once they saw his signature, it really became more personal for them. And I highlighted the fact that this was going to be a study to benefit African Americans and the African American the community and the African American family specifically. I did not do any cold calls and calling people, because people get a little perturbed when you call them out of the blue talking about end of life and a person that has just died 2 to 4 months ago. Not a good situation. And I tried to avoid major holidays, and this was a lesson learned. I tried to avoid Mother's Day and the decedent's birthday. I called one participant, and it was very close to Mother's Day, and she was not able to participate because it was her son. It was her son that had passed away, and so trying to avoid holidays was a key strategy. Speaking with participants, every participant I spoke to got the same experience. I used flowchart telephone script. I introduced myself as an African American nurse, researcher, and I assured them that this study was going to benefit African Americans. This is an example of a piece of the script. So I called them, I greeted them, I introduced myself. I told them that I was connected with Dr. Gramos Falker, who was with the palliative care program. I told them a little bit about the study, and I asked them, were you involved with the patient's care? If they said yes, then I said, okay, wonderful. Did you get the information I sent you about the study? If they said no, they weren't involved with the patient's care, I asked them, well, if you weren't involved, could you please tell me who was involved, and do you mind giving me their contact information? So my recruitment strategies were highly successful. 85% of the bereaved family members that I contacted consented. 100% for the first portion of the study, 100% consented for the second portion, And like I said, with reasons for refusal was emotionally, one woman was not able to participate, and then one person was not African American. So lessons learned. Language sensitivity in the introductory letter and the recruitment or the study information sheet is very important. The participants' knowledge that this is going to benefit African Americans and that I was an African American conducting the study was extremely important. I actually had one participant ask me from the beginning, "Are you Black? And is this going to help Black people?" And so I said, "Yes, I am Black. Can you not tell by my voice?" And yes, this is definitely going to help Black people. And she's like, "Okay, all right, well, let's go." The timing is very important. Being sensitive to major holidays, and this is a small amount of time from the time their loved one has died. And so I had several people during the interview process cry. They wanted to tell stories about their loved one. One woman she read me the poem that she wrote for her son's funeral. And so it was very important for her to let me know something about her son and how great of a person that he was. So taking that extra time to make them feel like their loved one was valued was important. And also being aware of the participants' emotional responses. So although this has been, African Americans have been historically low to participate in research, employing effective strategies definitely can increase the participation of this hard-to-reach population. So I think in the future, I will employ similar strategies and hope for the same amount of participation. Any questions?
Do you have any records?